Hi everybody, welcome to this lesson. This is lesson 8. Today we're going to talk about Guillain Barre syndrome. And so this is actually a favorite topic of mine when we're studying about neuromuscular diseases, because I think that it's very interesting. It's kind of a unique diagnosis and something that you don't see all the time, but when you do, it's pretty memorable, the things that happen with these patients. In the course of my 19 years of being an OT, I probably have seen 4 to 5 patients with Guillain Barre. There's a lot of discussion in the literature about what causes Guillain Barre, and in the studies that I've done about it, there are a lot of discussions about the effect of the immune system with Guillain Barre and how the immune system helps or hurts the patient when something causes a trauma to the immune system. So something like a surgery or a sickness. There have been many, actually most of my patients develop Guillain Barre following their flu shot. Now there are a lot of controversies about that, but I think the concept is that the flu shot itself is not what is to fear. It is the fact that the immune system is down, and whenever there's an attack on the immune system in some way, it can cause Guillain Barre. So it isn't that any of these things particularly cause the Guillain Barre. It's just kind of a cataclysmic result of my immune system is down. I have this some kind of attack to my system. Something's introduced to my system that makes my immune system try to defend itself and essentially cause a war on the patient's well-being. So we're going to talk about the different symptoms and signs, but let's talk just a minute about what it looks like when you have Guillain Barre. So if you look at the picture on this slide, if I'm looking at the slide, the one to my left is the healthy nerve, and you can see that around the axon of the nerve, the axon is where the message is being sent, right, to the next neuron. So to get these, to get multiple messages down from your brain to your limbs, you've got to have these axons of these neurons that are producing neurotransmitters, and they're sending these messages down the line. So the myelin sheath is covering the nerve axon, and if we think about other progressive diseases where there's demyelination, another example would be multiple sclerosis. So what happens here is we get this demyelination or this damage to the myelin sheath, and that's what happens. And when that happens, conductivity of this nerve is interrupted. And so we see what's very common also in diseases like multiple sclerosis, where there's a disruption to these messages, and so we get difficulties using our limbs and our body in the way that we want to be able to use them. So another picture of the damaged myelin. Guillain Barre is an interesting progression, because here's what happens. It rapidly onsets. A lot of times, and a lot of my patients that have had it, they progress very quickly to motor paralysis. Now, it may be that they progress only to motor weakness. They have some pain and tenderness. They have weakness in the muscle, but it can go all the way to paralysis. And interestingly, it looks just like spinal cord injury, except that you haven't gone in a car accident, you haven't had a skating accident or a diving accident or something that's caused you to have damage to your spinal cord. This is purely related to the neurons and the nerves. You might have sensory loss. Muscle atrophy means that the muscles have, because they're not able to be used, they kind of shrink down, so they become smaller, and you get fatigue. So there's a lot of different kinds of symptoms with this, but I will say in the patients that I've had, every one of them it has progressed to paralysis. Now, again, you're going to see all different kinds of things in the literature, and that's just my clinical experience. Okay, so this is again just this picture again. One of the things that's often affected in the Guillain-Barre diagnosis is the cranial nerves. So what you want to do is you want to look at the cranial nerves. I don't know how much cranial nerve training or education you've had during your neuro class, but the cranial nerves are in the brain, and these nerves originate in the brain and then lead to some other part of the body, and usually the parts where they're leading to are going to be more in the facial area, more in the upper part of the body. So these cranial nerves are identified by the number, so you can see each has a number, and then they go down in order. My suggestion to you is to create a we may not have to know this specifically for this quiz, but you need to have some kind of mnemonic or some way to remember these cranial nerves. And the cranial nerves each have specific skills and tasks that they are responsible for. And so depending on what's affected within the Guillain-Barre is going to depend on which cranial nerve is affected. Okay. If we look at the medical complications of the cranial nerves, and not just the cranial nerves, but other nerves that are affected, we see patients may end up with a tracheostomy. They might end up on a ventilator. These two pictures demonstrate that for you. And I'm going to pause just 1 second. Okay, I apologize about that. I had just a little bit of a computer issue. Okay, so one of the interesting things about Guillain-Barre is that patients will often go through this very quick progression into breathing difficulties and motor difficulties and all these different medical complications. But then the difference between this and another type of progressive disease is that it actually does improve. And so the patient will have this very rapid onset, and then they cycle through these symptoms, and then they will actually start to improve. And so some patients that I've had have been completely paralyzed in the acute phase, and then they cycle around, and then they become completely back to total independence with their ADLs and things at the end of this cycle. Some, not all, do progress in that manner. Some do still have some issues that will linger on for a while, or maybe forever, depending on what their situation is. So that's an interesting part of this diagnosis that's a little bit different than you may see in other diagnoses. The other part of this is that the person, it may be a rapid onset, or it may occur over several weeks, just getting progressively weaker and weaker. And so generally you're going to see people start to have weakness, difficulty using tools with their hands, being able to manipulate objects, being able to use both their hands at the same time, some kinds of sensation loss or some kind of different sensation issues. I'm going to go back just a little bit to these cranial nerves, and also this wanted you to kind of see some of the other problems that people may have. So they may have issues with their facial expressions, their taste sensations, the sensations of their face, their mouth, sometimes difficulty swallowing. They have a difficulty managing the saliva in their mouth. So these are all things that we want to just really be aware of. So generally, it's going to be the cranial nerves 7, 9, and 10. So the facial nerve, Okay, the glossopharyngeal nerve and the vagus nerve are the three that you're primarily going to see interrupting function in the patient. So let's talk about terms that we remember from before in stroke. Similar terms here. So dysphagia, the inability to swallow or difficulty swallowing. Dysarthria, difficulty speaking. So a weakness of the muscles of the mouth. Difficulty breathing. So and just if you haven't experienced a tracheostomy before, one of the things that happens with this, that it has to have a specific kind of valve on it for them to be able to talk. So if somebody has a trach tube, they won't be able to talk to you unless they have the Passimere valve on there. And so you'll need to know for sure if they have a specific valve on there for talking. You'll be able to tell because they won't be able to respond to you when you speak to them. They can mouth words, but you won't be able to hear it. And the other thing that these patients may need suctioned quite a bit while you're working with them. And so you want to make sure that you know the procedures in your facility, whether you're allowed to suction patients, whether you need to have further training on that, or whether the nurses or the respiratory therapists are the ones who are in charge of doing that for you. Somebody may have, they're always at risk for pressure ulcers because they're not moving very well, and they're at risk for contractures for the same reason. The contractures, let's talk just a minute about what the difference between a hypertonic or spasticity and contractures. So when people have spasticity, or when people don't move for a certain amount of time, what happens is you get shortening of the tendons and the muscles and the ligaments at those joints. And what can happen is if over time you're not moving and stretching those, they can become shortened. If they become shortened, that's just a stretching issue. We need to stretch. All of us will experience that from time to time. If we're dehydrated, that happens. But a contracture is where bony growth has actually taken place there, and you will not be able to move that limb from that position without breaking the limb or surgically changing that limb in some way. So a contracture is not something that an OT can fix. We try to splint people, we try to stretch them to keep from getting contractures, but once a contracture happens, if it is stuck in that position, we cannot fix that. It has to go to the surgeon for assistance with that. Possibly if it's a pretty new contracture, we might be able to do some casting or something to pull it back out into normal, but that takes a very long time, and that's a slow progressive process. So we just don't want them to get into that situation. Here you have a bunch of precautions that are listed. So these patients, you're really going to need to watch for their vitals, making sure you're checking their blood pressure and their heart rhythms, making sure that you're watching for the signs of blood clot, which remember are things like a redness on the leg, or heat coming from that area, pain in that area. But remember, these patients might have sensation loss, and so they don't necessarily feel that that blood clot, the pressure or the sensation, the heat, the pain from it, so you need to be cautious of that. Looking for things like low-grade fever, which are signs of infection, which if you remember could be a sign of aspiration also, meaning you're taking food down into your lungs, and that low-grade fever is giving you, that's a sign of infection. Even a 99, 100-degree fever, you're wanting to pay attention to that. We really want to make sure that these patients aren't getting too fatigued, because they might be having this progression, and if we fatigue them, sometimes we can actually progress them even faster, as well as if we're fatiguing their muscles, we're not increasing their strength, and then we might wipe them out for 2 or 3 days where they can't do anything. So these are things to kind of be looking for. If the patient is in therapy, then we talked about muscle weakness, muscle atrophy, paralysis. We talked before about paresis and plegia, and remember that plegia is full paralysis, paresis is muscle weakness. So if it occurs on one side of my body, it's going to be hemiparesis. but this will be bilateral paresis or bilateral plegia, because this person will have just overall weakness. Difficulties with functional mobility, so the person is going to have some difficulty, likely. Most of my patients who have had Guillain-Barré have not been able to walk well. Eventually they get to the point where they're in the wheelchair, but that isn't always the case. Fine and gross motor deficits, again, varied from just some difficulty manipulating objects to complete inability to manipulate objects. This could be a really scary diagnosis, I think, for people, because they don't really know what the progression is going to be, and they don't know where it's going to stop and how well they're going to get. So I think it can be a little bit terrifying for some people. Okay, so the person will have decreased endurance. That's something that you're going to have to be aware of. The difference between endurance and strength is strength has to do with muscle resistance. Endurance has to do with using your muscles over a period of time. So they will have muscle weakness, not being able to work against resistance, but then also fatiguing or getting tired after just a little bit of effort. So that has to do with endurance. Decreased sensory awareness, abnormal sensations, things just feel weird to them. Problems breathing, speaking, swallowing. We have these things that we talked about before with the blood pressure and the heart rate. They might use a respirator. I actually haven't had any of my patients that have had to be on a respirator, because when I saw them, mostly it was in rehab and they were already off the respirator, but in acute care you would definitely see them on the respirator. You can still do activities while they're on the respirator, but you just need to realize that their ability to speak to you is going to be less, their endurance is going to be less. They may be more centered on bed activities versus getting up and doing full ADL sessions, maybe edge of the bed more than getting up and doing full sessions. What you see on this page, this is on this girl's hand. This is an adaptive device to help her be able to use the fork. It's called a universal cuff, and the cuff is there's a pocket on the underside of that where you can slip an object like a pencil or a fork there. You can put a comb in there. There's different things, but the pocket allows you to hold that tool. The person doesn't have to have grip if you use a universal cuff, so this is something that you might find useful. Really, for this particular problem, which we're going to study, I think, in future semesters. Well, I know for sure we're going to cover in future semesters, but I don't think we're covering spinal cord injury this semester. But the material for spinal cord injury, the book information for spinal cord injury, could be very helpful to you in your treatment of patients with Guillain-Barré, because you're really seeing very similar results to that. Of course, if I am paralyzed, I'm going to have difficulty with these ADLs and IADLs. My work and play. So I've had a couple people who were, the interesting thing about Guillain-Barré also is that when we're working in rehab, for instance, many of our patients are 65 years and older. The interesting thing with Guillain-Barré is that a lot of times it is younger people that are having these issues, and so they are working. They're not retired. They're working. They need to be able to get back to their work. They need to perform their social roles that they're involved in. They have leisure activities that they're doing. They have families to take care of. So it's an interesting diagnosis, I guess, from that perspective. It really opens up a whole lot of areas for you that maybe in other patients won't be issues. I put this picture of the guy in the Army because one of my patients was a guy in the Army. He had had a flu shot because the Army had required him to do that. He had been ill and had gotten that shot and then developed Guillain-Barré. He was trying to he was active duty. He was trying to be able to do all the things he needed to do for the Army as well, for his responsibilities for that. And that was a very stressful time for him. He did fully recover from his diagnosis, and one of the things that they did for him was a treatment called plasmapheresis. So if you're not familiar with that, plasmapheresis is a medical situation where they actually filter your blood. It's a similar process to dialysis, but they filtered his blood on a regular basis to take the impurities and the toxins out and to help him recover from the Guillain Barre faster. And it was very successful for him. So plasmapheresis might be something that you hear about. Cognition is not directly affected by this, but again, like I said, it is kind of a frightening experience because you don't understand why it's happening. A lot of times it just comes out of the blue. And after this surgery, I had a woman who went in for a surgery for something real minor and developed Guillain Barre after her surgery, and it was made her very fearful and unsure of what was happening because it wasn't anything related to what she had gone into the hospital for to begin with. So depression is not uncommon, anxiety is not uncommon. So get patients a referral to the counseling services that are provided in your facility, or outside counseling services if necessary. I think that's an important piece for them. So the things that we're going to do for patients with Guillain Barre, if the patient, we'll learn this in future semesters, but if the patient is at zero ability to move, then you're going to do passive range of motion. If the patient can do part of the motion and you can do part of the motion, then active assistive range of motion is appropriate. If the patient can do the entire motion by themselves, if they can raise their arm all the way above their head, or bend their elbow all the way up, or bend their wrist all the way back, then that's active range of motion, and then they need to be doing the exercises themselves. Generally, we're going about 10 repetitions, and we try to do 3 sets of 10 as a goal, but 10 repetitions at least if this passive range of motion or whatever type of exercise you're doing. You wouldn't add resistance until the patient is able to take that resistance, which may be a long time from the beginning of onset. We will use some different splints to prevent contractures and deformities to help position the patient so that they stay in a functional position. There's a splint called a resting hand splint that positions the hand just like this, and this keeps the hand in a functional position so that when the patient is able to move again, they haven't lost that joint range of motion. We don't want them to be in a curled position in any way. We want their hands to be open so that they don't get stuck in that position. And we might do some sensory testing to see what they're feeling. That's more for an adaptation. We want to make sure that if they're not feeling things correctly with their arms, for instance, things like bath water, we would want to teach them to use a temperature gauge, some kind of thermometer, being able to use whatever part of their body they do have good sensation. So if one side of the body they don't, the other side they do, teach them to adapt and use that other hand would be important. Practicing their self-care activities, this is going to be a major part of your session. You're going to be working on things like your dressing, your bathing, your toileting, transferring for sure, teaching them how to do those things with education for energy conservation and pacing. Sometimes you have to use communication devices with these patients because they're not able to communicate, but definitely positioning and really just trying to get them back to the things that they were doing before. So if they did work before, you're getting them back to that kind of thing. So generally what we're doing always is trying to get them back to levels of occupation. So those areas of occupation, ADL, IADL, work, play, leisure. But within that, sometimes we have to do what we call enabling activities. So we might have them working on handwriting. We might have them working on fine motor skills. We might have them working on different little skills as far as reaching and grasping, things like that, to try to get those skills back to a stronger level. So in an acute phase, you've got 3 phases. You've got the acute phase, the plateau phase, and the recovery phase. And acute phase is where their symptoms are progressing, and so their function is going down. The plateau phase is they're no longer going down, but they're not getting better. They're maintaining. Then they'll go into the recovery phase where they start to gradually get those skills back that they had lost. Really, in the acute phase, what you're trying to do is keep them safe, keep their body moving as much as possible, keep them from getting contractures. When we start to look at movement again, we really want to work on the proximal muscles first, work on the trunk, work on the shoulders, then as they progress, work more towards the hands, because without a good solid hand or solid shoulder function, the hand is pretty worthless. So we're not using too much progression of resistive activities at this point in the plateau. We're mostly using muscular movements, so active range of motion, active assistive range of motion if needed. Remember, if they can do part of it and you have to do part of it, then it's active assistive range of motion. And then as they come back into that recovery phase, we work on fine-tuning all of those skills that they had lost before. Really wanting to make sure that we know what it is that they want to do and what's important to them so that they can feel engaged and supported through that difficult time, and really providing them with enough emotional support, which might not be through you. It might be through the support of their family. It might be through the support of maybe there's a neuropsychologist that works with them, the social worker. We're just making sure that we're really providing them with hope. And really, I think it's really important to educate these people on the progression of this disease, because the progression is just different for this disease. Not everybody recovers in the same way, and so we need to tell them about the plateau and the recovery phase, because some people will just think, am I going to be this way forever? And that's really frightening for them. Okay. Also in their environment, working on things like being able to use, they might be in a wheelchair and they might not have been in a wheelchair before, so you might have to teach them to use their wheelchair in their house, making home modifications, facilitating different aids in their house for them to use. If they've not really hit the recovery phase, that's something to think about. And then looking at their equipment, making sure they have the right equipment for when they're going to go home if we're treating them. And the important thing, I think, for these patients too is a lot of this equipment is going to be temporary. It is not going to be a permanent situation for a lot of them. So I did have a patient once who had this, and he again became fully paralyzed. He fully recovered, and then after another incident, actually had Guillain Barre twice, which was very scary for him, but he didn't recover as well the second time as he did the first. So you know, just really educating and staying connected with patients about what strategies they need to use and what do they want to be able to get back to doing, I think is really important for this patient. So if you have any questions, please post on Ask the Class, and make sure to watch the videos so you have an idea of what's happening there, and I'm glad to help you with anything. I hope you have a great week, and I'll see you soon. Bye.